Triage in disaster and damage control surgery. Triage and damage control surgery are critical components of disaster medicine and emergency surgical care. These approaches are designed to optimize outcomes by prioritizing care for those most likely to benefit, even under conditions of limited resources. Triage in disasters. Definition. Triage is the process of categorizing patients based on the severity of their injuries and the urgency of medical attention required. It aims to maximize survival and ensure efficient resource allocation in mass casualty incidents, MCIs. Types of triage. 1. Primary triage, conducted at the site of the disaster. Focuses on quickly categorizing victims based on visible injuries and vital signs. Utilizes triage tags, color-coded, red, immediate. Life-threatening injuries requiring urgent intervention, e.g. airway obstruction, severe bleeding. Yellow, delayed, serious but not immediately life-threatening injuries, e.g. stable fractures. Green, minor, minor injuries or walking wounded, e.g. abrasions, small cuts. Black, expectant deceased, victims with little or no chance of survival, e.g. massive head trauma. 2. Secondary triage, conducted at healthcare facilities, reassesses victims to refine priorities and determine definitive care needs. 3. Tertiary triage, occurs within operating rooms or ICUs, guides resource allocation for ongoing care, especially when resources like ventilators or surgical teams are limited. Factors considered in triage: severity and type of injury, physiological parameters, e.g. respiratory rate, heart rate, consciousness level, available resources and capacity, likelihood of survival, damage control surgery, DCS. Definition: damage control surgery is a staged approach to managing critically injured patients. It emphasizes life-saving interventions to stabilize the patient before definitive repair of injuries. Principles of DCS. 1. Control of hemorrhage. Immediate efforts to stop life-threatening bleeding, often using techniques like packing, clamping, or vascular shunting. 2. Prevention of contamination. Temporary closure of open wounds or abdominal cavities to prevent infection and further contamination. 3. Avoidance of further physiological deterioration. Minimize time in the operating room to reduce risks of hypothermia, acidosis, and coagulopathy, the lethal triad. Phases of damage control surgery. 1. Phase 1. Initial surgery. Perform life-saving procedures, e.g., control bleeding, prevent contamination. Temporary measures like packing wounds or using external fixation for fractures. Phase 2. Resuscitation in ICU. Stabilize the patient physiologically. Address hypovolemia, coagulopathy, and acidosis. Perform imaging studies to plan definitive surgery. 3. Phase 3. Definitive surgery. Once stabilized, the patient undergoes final surgical repair of injuries, e.g. organ repair, wound closure. Indications for DCS: severe trauma with exsanguinating hemorrhage, major abdominal injuries, multiple injuries with systemic instability, inadequate resources for prolonged surgeries in disasters. Integration of triage and damage control surgery in disasters. Challenges: limited medical staff, surgical teams, and resources. High volume of casualties requiring simultaneous care. Dynamic patient conditions that may necessitate re-triage. Strategies: 1. Efficient communication. Establish clear lines of communication between triage teams and surgical units. 2. Coordination. Utilize trained personnel to prioritize and direct patients to appropriate care areas. 3. Flexible resource management. Apply damage control principles to maximize resource utility, e.g. performing multiple temporary procedures in the same operating session. 4. Training and preparedness. Train responders in triage protocols and damage control techniques. Conduct regular disaster drills to improve response efficiency. Conclusion: triage and damage control surgery are indispensable in disaster scenarios. By prioritizing care and implementing life-saving interventions, these strategies improve survival rates and optimize the use of limited resources. Effective planning, training, and resource management are crucial for their successful execution in mass casualty events.